Okay. Okay. So again, we're going over. I kind of read through the more recent chapters as well. So hopefully this is corresponding to this additionally. So acute and chronic injuries of the ankle, as well as ankle arthroscopy. There's a separate chapter on ankle arthroscopy, but I didn't think that was really needed. So we'll just talk about it. And then a lot of the answers to the questions that we'll be going over will also incorporate a lot of the things through the chapter. So again, hoping to keep it interesting and hoping to keep you guys awake. Okay. Okay, so the most common athletic injury is obviously the ankle sprain. As we've all seen for staff, 85% involve the lateral ligaments. Varsity basketball players, even in their early years, 15 to 19-year-olds, 75% had ankle sprains. So something that we see every day. You guys are going to see a lot of these in general. I'm sure you get called from the ER a lot too, so we'll go over some of those things that you don't want to miss when you do get called. So the history is usually a plantar flexion inversion mechanism, as you all know. The physical exam is really key here, especially in differentiating these other conditions that sometimes we don't want to miss. So really, it's most likely we see tenderness at the distal fibula. So you can see here anteriorly along the fibula. So when we're talking about these other things, these other disorders, you just want to make sure that you do a really good physical exam. So largely the ATFL and the CF are most common injured ligaments. And so that's again along the anterior and distal tip of the fibula. So if they come in with a really swollen, super bruised ankle, then a lot of times if you're worried about something, we'll have them come back and re-examine them if we're worried about one of these other injuries that we treat very differently. Okay. So the pathophysiology, as we just talked about, the ATFL injured 66%. So a majority of our ligaments extending again from the distal anterior aspect of the fibula into the neck of the talus. And then the calc fib ligament is the second most commonly injured ligaments, stretching from the tip of the fibula, actually posteriorly, not even vertically as this picture, but there's about 100-degree span. And that's why it really incorporates the full array of the range of motion that that your ankle does. 70% of new injuries, again, the ATFL is most commonly injured. We worry less about the PTFL, largely because of the natural structure of the ankle joint itself, in the sense that there's a posterior malleolus bone, which really inhibits the talus from going posteriorly. And that's why you can imagine the posterior, the PTFL is not commonly injured. And we just don't worry about that as much, largely for that reason. So the anterior drawer test, again, test the ATFL. Key is, again, you want to make sure the ankle is in plantar flexion about 15 to 20 degrees. And why is that? That puts the ligament on stretch. And so largely what you're doing is you're holding the tibia and then you're translating the talus forward, as you can see in the picture on the right. And some people naturally are more flexible than others. So I think a good way to do this is to always examine the good side first. And like I said, some people naturally are more ligamentous lax. And so you're really largely trying to see how much translation you can feel from the talus as compared to the distal tibia. And the more you do this, the better. I think a lot of residents come in and have a tough time doing this, which is totally understandable. But I think the more ankles you do, so I just tend to do this on everyone, meaning if you watch us do our physical exam, and every time people come in, you just get into a routine of doing that. And then you actually start noticing a difference between the two sides and noticing a difference amongst patients as well. Okay, so Talar Tilt, again, CF in neutral dorsiflexion, again, puts the CF ligament on stretch. You can see this clearly as a problematic here. But you're looking at the angular degree of the talus as compared to if you drop a plumb line down the distal tibia. Again, looking at it compared to the other side. And a lot of times, if you do really have a problem doing a physical exam, meaning they're swollen or they're sore or they're really tender, then a lot of times we will take them to the fluoro, as you can see, and really stress this, and then you can actually get an accurate measurement. Additionally, some people do a stress exam, like a normal x-ray, but that requires someone obviously to be in there stressing the ankle with lead gloves, and it takes a lot more effort and time. But there are some people in the clinical setting that actually will do that as well. For us, we just do it in the fluoroscopy suite, just because it's easier and more convenient. So when do we get x-rays? I'm sure as most of you have heard, the Ottawa criteria really defined for a lot of, especially ER doctors, when they should get x-rays. When that includes any pain at the malleolar site, so the medial or lateral malleoli, inability to bear weight, and any bony tenderness, not just at the fibula or medial mal, but also at the navicular, as well as the base of the fifth metatarsal. At this point in the game, though, usually when we're seeing these, most of the patients expect x-rays. So by the time they come to us, most of them are getting x-rays. But the key also from our standpoint is to really get weight-bearing x-rays if possible, because that can change the alignment. Additionally, as we know, when people are standing versus when they're sitting. So classification, I'm sure as you all know, grade 1 sprain really is really no disruption of the ligaments, as you can see. Grade 2 is an incomplete or partial tear, and grade 3 is actually categorized as a torn or fully ruptured. And this is also important because if you are looking at MRIs, I think a lot of people, if you get an early MRI after an ankle sprain, a lot of patients actually get really alarmed, thinking, "Oh no, I need to have this repaired or fixed because it's completely ruptured." And so I think it's really important to educate patients that a grade 3 sprain is actually a complete tear. So again, what is our treatment? RICE, as you all know, rest, ice, compression, elevation, and then the key is really rehab. And we know that early, so people can talk about air cast versus a boot. Grade 2, we think maybe an air cast again because it's partially torn. Then the key again is rehab. In grade 3 is actually put people in a boot. But the key for all of these is really early weight bearing and bracing with functional rehab. And we definitely know this. And so I think that we've seen also quite a few patients that come in non-weight bearing for weeks, and they are really tight, they're really stiff, and they actually have a harder time recovering. So we tell people it's really guided by pain and tenderness. So we do allow people to do protective weight bearing and get them into the functional rehab. There you go again. So why do we put people in a boot? Because again, it brings the ATFL together. You can imagine if the foot is in plantar flexion, with the ATFL ligament is found to have a gap of several millimeters. So again, our goal is really, even in a full thickness tear or grade 3 sprain, we really are trying to maximize the chance of them healing. So we still, even with a tear, give them the benefit of the doubt, trying to get this to heal without surgery, because a majority of people after even a bad ankle sprain don't need surgery. They just need longer to recover. Okay, so no conclusive evidence to support operative treatment, even for a complete tear. So this is key. So restoring range of motion, regaining strength, specifically of the perineal muscles, and then proprioception. So functional rehab, again, most important factor for recovery. Balance, proprioception, here you can see examples of that. And then when to return to sports, cutting, running, and hopping on the effective leg does not cause pain. We know 90% of sprains, again, resolve with early functional rehab. The physical therapy is largely focusing on isometric exercises, resistance training, perineal strengthening, as well as range of motion, proprioceptive training. When do we get an MRI? We usually wait until about 6 to 8 weeks, but it largely also depends on how the patient is doing, meaning are they improving? But if the pain persists, if they can't get out of the boot, or it really is, realistically, if it is in any different location than the ATFL or the CF ligament, then sometimes we get that earlier, again, because that changes our management largely of these things that we really don't want to miss. So again, educating the patients is important because everyone with any prior history of sprained ankle has irregularly appearing ligaments on the MRI. And a torn peroneus brevis tendon is not always symptomatic. So people also come in thinking, oh, I have a tear, I need surgery, because the tear of peroneus brevis, which we'll talk about a little bit later, is more of an attritional flattening. So it's more of a wear and tear process on the tendon. But when patients hear that, they think they immediately need surgery, which again, we'll talk about in a little bit later, is not always the case. Okay, and so here we go. The fun begins. So no, I mean, quite honestly, hopefully this will encompass a lot of things that we're talking about. So we'll start with Hunter, because you're on the service. Hopefully you're there and not asleep. So I'm going to start with you. You're going to read this and then make a choice answer, and then you will choose the following person for the next question.
Right. So figures 1 and 2 are the T1 and T2.
No helping, Pagani. No helping, Pagani.
Volleyball. She was unable to bear weight for 3 days. Management by her primary care physician for an ankle sprain included using an elastic ankle brace and undergoing PT for 12 weeks. She continues to have pain and instability with ambulation, aggravated by uneven terrain and pivoting, and has a popping sensation with severe pain up to 3 times a day. What is the best next step?
So best next step. So
we have actual T1 and 2 cuts.
We're going to show you. I'll show you these zoomed in. Here they are. Great. So what do you see here?
Awesome. Let's see. So let's see. Looking at the lateral side, looks like we have, ATFL. Looks like it's out. Like we calling your ankle instability. Looks like we have maybe some tenosynovitis around the peroneal tendons as well.
Mm-hmm. And so going backwards here, what else do you see here, Pagani?
Okay, sorry.
Can you ask? You can ask a friend for help too. Pagani, you're on mute. You're still on mute.
Sorry, we're in the same room and trying not to get the reverb, so I had to mute.
Oh, got it.
Not the savviest technical. I'm too old for know how to use computers. Did you guys hear Hunter talking though?
No.
Oh, perfect. Hunter wants to just come over here and do it.
I was able to hear Hunter.
Sorry. Cool. So we have.
We heard him. We heard him.
Oh, you did. Okay.
Oh, so you want to go back to the answer choices, Dr. Olson?
Yes. I'm trying to. So what are your thoughts, Hunter? What are you thinking about this?
So it sounds like the history sounds like, acute lateral ankle instability, which has not responded to non-surgical means. So I think it would be reasonable to start talking about surgery at this point in time. You have like the perineals look pretty like you have significant inflammation and subluxation around the fibula there.
Yeah, exactly. So this you can see is the perineal, right? And this here.
Yeah.
And then you're right. So the ATFL is out also. Mm-hmm. So what is your thought for this lady?
Yeah, so, because the perineals are grossly subluxating out on MRI and likely also on exam, I would say A would be the most appropriate choice here.
Right. Because again, as we'll talk about later, dislocating perineal tendons are very difficult to get to go away without surgery. People talk about passing for 4 weeks or so, but technically the board answer and the test answer is you do operate on these right away. And again, the lateral ligament reconstruction, she's undergoing physical therapy, but she has this popping with severe pain. And so that's why we're thinking in combination with the MR, showing us the dislocating perineal tendons. Okay, next one. Oh, actually we can read this here.
You want me to read through that?
No, I think everyone can read through it.
We all know how to read, Hunter.
You're welcome to if you want to.
You want to hear my soothing voice go through it?
But largely, like we were talking about The key is identifying this early. How do you identify that? Pain posteriorly, or the posterior aspect of the fibula, not the anterior, right? So just like we talked about a couple slides ago, physical exam is always key. So you have to examine the patient and make sure, again, if you have any concern for this, then you either bring them back or you send them for an early MRI, because the treatment is very different than an ankle sprain, okay? And it's something you're trying not to miss, all right? Okay, you choose the next person. Hunter. You're choosing the next person to answer this question.
I'll volunteer.
Thank you, Anthony.
So figure 1 is a T1 weighted lateral MR, and figure 2 is a T2 weighted lateral MR of a 25-year-old woman with ankle pain for the last year that is associated with walking downstairs and playing sports. No known injury has been identified. Ankle pain has been managed with rest therapy for range of motion and a period of immobilization. Intra-articular steroid injection provided limited relief of symptoms. And what is the next best step? So if we,
Okay, so
yeah, if we get a zoomed in image here. So
what do you see there?
Let me see. So looking at a sagittal image of the ankle, we have T1 on the left, T2 on the right. The subtalar joint, at least in the T2 weighted image, there appears to be kind of some sub-signal there. And then posterior, there's sort of like an os. But in terms of—
What do you see, yeah, what do you see around that os?
some inflammation. It looks like there's a bit of a fracture.
Yeah. And yeah, you can see there's definitely a line here, but there's also fluid like around it and across it.
So
what is your—
Yeah, so looking back at our choices, PRP, ankle scope, posterior ankle scope, posterior tendon repair. So I would favor, so she's already had an injection. I wouldn't go for PRP. So I would consider a scope to kind of see if we can get to that fracture fragment and try to debride it.
Anthony, what's marrow stimulation? Do you know what they're talking about here?
So that basically like microfracture?
Yes. So when would you think you'd do that?
So if there were an OCD, I would think about doing microfracture. So
right. Do you see an OCD here?
No.
Right. So then what's that leading you to do?
So that would lead me to do a posterior scope with a debridement and try to remove,
and people do that
little piece.
Yes, exactly. And people do that. It's not as common, but it is something that's done. And it is in your book talked about. It's just, you know, we don't do it because making a little incision from our standpoint is much easier. But it is something that is done. It's just difficult to actually, it takes longer to actually set up the patient in that prone position down on the table and get the scope in than it does from our standpoint just to go in and remove it. And that's why from our standpoint, we rarely do this, but it is something that's done. But that's, again, all of these questions are all these answers are leading you to the specific one that's right. And that's why these questions are vetted, right? So that's why they're kind of associated with walking downstairs, and we'll go over that a little bit later. And so it's the steroid injections provide limited relief. So we're talking about surgery, obviously, and that would be the posterior, so because of the os. Okay. Okay, next question. You're supposed to choose the next person, Anthony.
All right. Let's see who's got videos on. Dr. Freshman, you want to take one?
Sure. Sorry, I didn't get a chance to read the question here, Dr. Olson.
Yep.
All right,
Yep.
figures 1 through 3
Sure.
are CT scans of an 18-year-old who sustained an injury 3 weeks ago, now has ankle pain, has an ankle fusion on exam and painful range of motion. Treatment should consist of, okay. We can go to the CTs.
Mm-hmm. What do you see there?
Okay, so there is, so yeah, it looks like there is a osteochondral lesion on the lateral talar dome, kind of at the shoulder region.
Mhm.
And there's a displaced fragment in the joints.
Right. So in displaced fragments, what do you think you are going to do?
So your options are to either resect it or fix it, because you don't want that thing floating around in the joint.
Right. So you
looking
need surgery, right? So surgery. So not weight bearing or cast.
Yep, not either of those. And then out of those three, trans-talar drilling, I would not do that because you need a cartilage cap in order for that to be successful. So that's not good. Between the other two, fixation versus autograft, probably try to fix that first as opposed to immediately going to an autograft.
Exactly. And they're a young child and, or I didn't say child, but young teenager. And it looks like there's a bone piece there. So and then the reason that you do this is because largely you're not going to go to an OATS right away, right? They don't give you the choice of they're not going to tell you fixation versus microfracture, right? They're going to lead you to this answer. Does that make sense?
Mm-hmm.
Okay, next.
Okay, I'm gonna hand this one over to my gold team counterpart, Aviona Baldwin.
All right. 50-year-old male is having difficulty walking. He has a history of an injury 6 months ago. Examination reveals that he's unable to toe off and has increased ankle dorsiflexion compared to the uninjured side. He has a positive Thompson test, a full defect in the Achilles tendon. MRI scan shows a 4-centimeter defect in the Achilles tendon. What type of surgical resection should be planned?
So this is a little tough one, but the key is here, right? 6 months. And so he has this big defect. So it's obviously going to be really tough for when you have a big defect. You can imagine to get those ends to come together, because usually we repair Achilles tendons right within 7 to 10 days, because otherwise they get stuck down. So knowing that, what do you think you'd have to do? I don't know if you know this, but you may not.
Like an FHL transfer?
Sorry, I can't hear you, Aviana.
Oh, an FHL?
Yes, you do an FHL. And then a VY advancement is actually, what that does is it extends the tendon to bridge that gap. Okay, so this is a little bit more of an advanced question, obviously, but if there's significant scarring, and we'll go over this again later. So this is, again, all these questions are good introductory because I don't expect you to know the answers for these, but they're good because we will go over that today, a little bit later. But a VY advancement advances that when you're bridging a chronically deficient Achilles. If you have over 5 centimeters, then you do what's called a turn down. But we'll go, like I said, we'll go over that a little bit later. But you're right, FHL is exactly the right tendon transfer. Okay.
All right, we'll go with Charlie.
All right, so 45-year-old basketball ref reports having posterior ankle pain for the previous 6 weeks. Pain occurs mainly with prolonged and higher impact activities. Tender fusiform mass in the mid-substance of the Achilles tendon. What's the most effective initial treatment? So Achilles tendonitis kind of sounds like the diagnosis with some reactive sort of inflammation, intrasubstance in the tendon. So I think probably starting with some, I don't know if doesn't sound like he's tried immobilization yet, but I guess eccentric strengthening would probably be a good place to start for a tendonitis.
Correct. Yes. So non-insertional, main stress, eccentric exercising. And that will come up a little bit later as well. Okay.
We have more coming?
Yep.
All right. I'll go with Audie.
Keep you guys awake here.
I'll be on the line. Maybe Sarah Stroud.
Okay, let's
Yeah,
do
I'm
it.
here. Oh, okay, I can go next. That's fine.
Oh,
All right,
okay.
Sarah and then Abby.
Okay, sounds great. Operative arthroscopy is performed in a 25-year-old man with ankle impingement caused by Bassett's ligament. Appropriate treatment involves resecting the thickened distal fascicle of which ligament? So the anterior tibia talar, ATFL, transverse tibiofibular or posterior inferior tibiofibular. So just did a quick search because I personally had never heard of Bassett's ligament.
So Bassett's ligament, but you know what ankle impingement is, and we'll talk about this also a little bit in a little bit. Okay.
Yes. So
what would you guess?
Yeah, so I think about impingement as like an anterior lateral phenomenon, so that drives me towards the AITFL.
Right, exactly. And so when we actually go in and scope, you can actually see that, the corner of it, and that is something that we debride. You can debride it through a scope, which is nice. If people have anterior impingement, which is pain with reproduced with dorsiflexion. Okay.
Cool. So it sounds like the next person is going to be Abby.
All right. What is the relationship of the peroneus brevis to the peroneus longus at the level of the peroneal tubercle? So talking about between the peroneal tendons, brevis inserts. So I would say that at the level of the tubercle, it should be superficial.
It is dorsal. So where's the tubercle at? We'll go over this too.
Mm-hmm.
So tubercle is coming off of the calcaneus, and so that's distal to the fibula. And so after the tendons leave the common peroneal tendon sheath, and of course distal to the fibula, then they go into their separate sheaths, and the brevis is dorsal and the longus is plantar, and then it dives down along the cuboid tunnel. Do you know what I'm talking about now?
Yeah.
Okay. Oops. Okay. Next.
All right, we'll go to who's here. Alex.
Yeah, figure one is a MRI scan of an active 52-year-old golfer who fell getting out of a sand trap, describes a pelvic fixation and difficulty with ambulation. On examination, he has decreased resting tension of the tendon and has no plantar flexion with Thompson testing. What percentage of these injuries are diagnosed greater than 4 weeks out of injury? We have an MRI.
So what do you think he has?
Achilles tendon rupture.
Right.
Yeah.
So this is this you don't know, but what would you guess?
So asking like what percentage of these injuries are diagnosed in a more chronic nature. I think it's like a higher or lower. I mean, I just saw one in the ED 2 days ago.
Hopefully you diagnosed it.
It did. He had a positive Thompson test. He was resting dorsiflexion. He's going to see shear. But what percentages were diagnosed more chronically? I have to say, I don't know. I feel like people definitely feel the pain pretty accurately.
Yeah, they do.
Like 10 to 25,
Yep, 10 to 25, which is, it's high enough that like 25% of these get missed for a month out and they become chronic, which is why really important to have a high index of suspicion. But just like you said, they're painful initially, but then the pain subsides, which is why they do get missed. People think they just have an ankle sprain. And that's why it's really important. Again, we'll kind of go over this in a moment. Okay, I think we have about one more maybe or so.
Let's stick with the intern squad. Let's go with Ellen.
All right. So a 28-year-old man has a 3-year history of right ankle pain. He reports having an injury 3 years ago and undergoing subsequent arthroscopy and microfracture at that time. He's continued to have pain, locking, and swelling with activity. what factors shown on the MRI scans in figure 1 and 1 through 4 are predictive of a worse clinical outcome?
All right, so here they are.
So it looks like there's a large.
What do you think of that?
Yeah, so it looks like there's a large
Yeah.
osteochondral defect on the Talar dome.
Yeah.
And it's kind of in the center of the lateral, and then on the lateral side of the coronal view.
Yes, exactly.
Swelling.
So what do you think of, why do you think that this probably didn't work so well, the microfracture, which we'll again talk about in a little bit?
Yeah, so options, large
You
size.
you said it.
Yeah, large size and uncontained lesion. I don't really see.
Right.
Yeah.
Yeah, so the larger the sizes, and we'll go over that again. And it's uncontained, meaning it's not closed. So I tell people it's like if you're trying to fill in a big divot in your grass, if it's on the edge of a cliff, it's hard for that grass to fill in, right? It's uncontained. So this says also 1.5, which is traditionally what we had talked to people about. I know in the book it says 1 centimeter squared, so that's where there is a little bit of a discrepancy. But largely, they're not going to test you whether it's 1.2 versus 1.5. It's either going to be a small lesion or it's going to be a large lesion. Does that make sense? But this is kind of will go up to 1.5, but I know the book says 1. Okay, maybe one more.
Let's see. So, I'll say AJ.
Sounds good. Figure 1 is a radiograph of a 25-year-old soccer player who twisted her ankle 1 week ago. She has pain and swelling of the anterior lateral ankle, and there's ecchymoses of the lateral ankle. She has these muscle group findings: anterior tibial tendon 5-5, left 5-5, posterior tibial tendon right is 5-5, left is 5-5, peroneals 5-5, left 4/5, Achilles 5-5, and 5/5 on both sides. What is the next best diagnostic or treatment step?
Okay, so, all right, and what do you see here?
So what I see is this is like looks like a mortise view of the ankle. I see what looks like a distal fibula, like a avulsion fracture. And so, yeah.
Do you think?
Sorry.
So if you really look closely, I don't know if you guys can see, but there looks like there's a little avulsion fracture here at the tip. And this, what do you think about this? Does that look new or old?
That looks like it has it's somewhat corrugated, so it makes me think it's older.
Yeah, exactly. It looks kind of like it's older, almost like it's kind of happened a long time ago. It's very smooth, symmetric. Okay, so, but this may be new, this tip, probably representative of which ligament that we talked about that we injure commonly in the ankle sprain.
I think the most common is the ATFL.
Right. And then what's the next one at the tip?
Yes, the calcaneofibular.
Yeah, exactly. So probably calcaneofibular. So, oops, oh shoot, sorry, sorry. So what's your answer to that question? So what do you think is an acute sprain 1 week ago? What's your plan that we just talked about a little bit?
Yes.
What's the most important thing for this lady or guy?
So I think we should get some stress radiographs just to see if we can identify if it's unstable.
Well, I do understand your thought, because I just told you that was important. But if it's 1 week, it's not going to really change our management if she has an acute sprain, right? That we diagnosed her with our acute sprain, maybe an old sprain. So if it's an acute ankle sprain that's bad, maybe that involved the ATFL and CF ligament, what's our most important step for an acute ankle sprain?
We do physical therapy.
Right. Exactly. And so the stress radiographs We do. When we think that there's a chronic instability, just to document that, but we know she's probably going to open up with that little fracture there. But we do that when we are worried about chronic instability long term and we're considering intervening. But right now, that's not going to change our management really, because if it opens up, we're still going to put her in physical therapy, right? With proprioception and training and perineal strengthening, because her perineal is a little bit weak.
Okay.
Okay. Right.
Next, I could pick Syed.
Can you hear me? So figures 1 and 2 are the weight-bearing radiographs of a 17-year-old volleyball player who has a 2-year history of frequent ankle sprains. Exam reveals a stable endpoint with ankle ligament testing. What is the most appropriate treatment method for this boy? And we have the 2 radiographs. So it looks like mortise and lateral views.
So you want to see that again?
Yeah, if you don't mind, thank you.
Yeah. So what do you think of the ankle joint itself?
The ankle joint looks fairly congruent to me.
Yeah. Agreed.
I don't see any acute fractures. I don't see any obvious widening or instability. There's good overlap.
What about the lateral x-ray?
On the lateral, we see, looks like the tibia may be a little asymmetric with relation to the talus. Might be some posterior opening. Maybe there's like a little tiny crack in the fibula.
Maybe hard to see, but what I was looking at is, so if this is a young person with a frequent history of ankle sprains and they're only a teenager, and so all these things are kind of each step of these questions are giving you information. So they're young, they've had a history of ankle sprains, and but they have a stable ligament testing. So when you're thinking of young patients or young pediatric patient population with ankle sprains, what other things do you think come to mind? Because if they talk about ligament reconstruction, we know that ligaments are stable. Arthroscopy, we don't see an osteochondral defect. Syndesmosis, that looks okay. So what other things are you thinking?
Yeah. Yeah, for a young patient, I guess you'd worry more about something almost congenital, like a coalition or something like that.
Right. And so then thinking about that, then what then going back to your x-rays, do you notice anything else then abnormal when you're thinking about that?
Let's see.
I know it's a little tricky. It may be hard to see, but if you look here, looks like this is a little long here. They call this kind of this anteater sign.
Yeah.
And so what do you think that is?
Yeah, it looks like there might be a tarsal, calc-talus coalition.
Yeah, so a calcaneal coalition, exactly as you said, a coalition. So then what do you think you're thinking about doing for this guy if you have to do surgery on him, right? They're forcing you to do surgery here. So what's your surgical treatment?
Yeah, so for a coalition, I think we would do an excision.
Yes, exactly. And so, if you look at these choices, you can actually kind of also look at, we know the syndesmosis looks okay. We know the ligaments are okay by their second question or their second comment. We know the ankle looks okay. So then that's where it kind of also leads you to that.
Makes sense.
Okay, so now a couple more slides and then we will take a break. But this is kind of wraps up what a lot of things that we just saw. So things that you don't want to miss after a sprain is In lateral process of the talus fracture, anterior process of calcaneus fracture, osteochondral defects, base of the fifth metatarsal, and perineal tendon dislocations that we just saw some of those. So again, differential diagnosis, lateral process of the talus fracture, because these things, again, you don't want to miss because they're treated differently. So this is a snowboarder's fracture because what happens is that lateral process right here gets pinched between, you can imagine, the fibula comes down on the calcaneus. And the difference is, the difference is the mechanism of injury, which is a dorsiflexion mechanism instead of a normal ankle sprain, which is a plantar flexion injury. And so we see this with our snowboarders, we see this with our surfers, horseback riders, anyone who has hyperdorsiflexion. You always think about this as well as perineal tendon dislocations. Because again, we treat this differently because if it is small, again, the key is non-weight bearing. Whereas again, we just talked about weight bearing, early weight bearing with an ankle sprain, right? So this is why you want to diagnose this early. If it is large, we actually treat it with surgery. Okay? So you just need to, key is identifying this, again, if you have a patient who has an ankle sprain that's not getting better. Anterior process of the calcaneus fracture, which is what we can see here, right? This is the anterior process of the calcaneus, making up the CC joint. Again, treated very differently than an ankle sprain, which is early weight bearing, early rehab. So non-weight bearing, again, if small, ORF is if large. Foot fractures, again, looking back to Ottawa criteria, you don't want to miss fifth metatarsal fractures. Obviously, this is pretty obvious here, but I will tell you, I just saw someone who had an ankle fracture and then had a really bad Lisfranc that was missed because their ankle was swollen and painful, and they weren't examined, and then ended up needing to have surgical repair for their Lisfranc after their ankle fracture. Perineal tendon dislocation, which is what we saw on our first question, right? Again, dorsiflexion injury, same population here. Again, pain and tenderness at the back of the fibula. And this retinaculum is torn. This flex sign is really a pathognomonic sign here because, again, looking at this, when we just look at the tip of the fib, that's for the calc fib, anterior is where the ATFL. So on the lateral aspect of the fib, that's the only thing that's there. And so if you see a flex sign or a avulsion fracture here, you should immediately think of perineal tendon dislocation because, again, treated differently, right? We fix these. And so when do we operate on a sprained ankle? When people have continued instability after early weight bearing, early rehab, usually we often wait 4 to 6 months. The treatment for this is called a modified rostrum, and all that means is we tighten and repair both the ATFL ligaments, and the modified part of it is we add the lateral extensor retinaculum. Again, chronic ankle instability, people feel like they have continued episodes of giving way. We really want to evaluate for varus malalignment, which predisposes them. You can see this person here kind of has a really curved in heel. And we also, again, just like we just talked about, want to look for additional conditions that we also would address at the same time of surgery. Again, the key for chronic is always an anatomic repair. So in the olden days, we used to do these using the past slip of the brevis, but that created a lot of subtalar arthritis, and they were not anatomic because they would really create a lot of foot tightness. So our modified rostrum is really the standard, and that is because it's an anatomic repair. We do an anatomic reconstruction with allograft in our patient population that has ligamentous laxity, obesity, and sometimes a failed rostrum. So osteochondral lesions of the talus usually are from trauma or repetitive microtrauma. Medial tends to be more common, larger, deeper. The book talks about non-traumatic, or people talk about non-traumatic sources as of causing this, but now we're thinking it all of these may be from some type of microtrauma we just may not know about. 10% are bilateral. Again, causing swelling, pain, and also catching lockings and really mechanical symptoms. So here we go back to another question that we went over, right? Less than, I put 1 centimeter squared. Again, they talked about 1.5, but the key is, again, without deep cysts allows us to do this microfracture with the arthroscopy that creates a fibrocartilage, but you need an intact subchondral plate in order to do that. So fibrocartilage is like a scar tissue, whereas our oats is a much more invasive and bigger surgery. However, it creates more of a similar cartilage. Most of the ones that we see that we operate on do have a non-intact cartilage, but if they're big, greater than 1 or 1.5, then there's not a true standard of care which one is best. Sometimes we do juvenile chondrocyte allograft, but it has a big cystic lesion, and we often will do OATS. So, and then going over ankle arthroscopy, the key points are here. So largely we always put in an anteromedial portal. The risk there is really the greater saphenous nerve, saphenous vein is just medial to the tibia tendon. The mistakes that people make are sometimes they put it too medial, and then your medial malleolus gets in the way, and it's hard to get to the back medial, posterior medial corner. Anterolateral portal, the risks here that we see most commonly is really the SPN nerve, and specifically the intermediate dorsal cutaneous branch. Mistakes that people make here, it's too inferior. It actually should be about 5 millimeters above the medial portal. Posterolateral sural nerve is at risk, and people sometimes tend to make that too distal, and then it's difficult to visualize. The posterior medial portal is rarely done. I know that was on the questions. That's mostly only done with a posterior scope when people are in the prone position, but it's, again, not often done by most people. So anterior impingement, which is what we saw. Also, this can be categorized into soft tissue impingement, which is chronic sprain after one ankle, but often after multiple ankle sprains, and hypertrophy, just like we saw, of the distal ATFL. Sometimes it can also be of the proximal ATFL as well. The key is the tenderness along the anterolateral ankle reproduced with dorsiflexion. Bony impingement we also see after repetitive ankle sprains, and usually it's the distal lateral aspect of the tibia and the medial aspect of the talus, also pain with dorsiflexion. X-rays show the lateral view will show us the talus, and the oblique views will show us, lateral view shows the tibia, the oblique views will show us the talus. And often we can do an arthroscopy with spur removal only if there is no narrowing or arthritis of the joint itself, because clearly if there's narrowing or arthritis, removing the bone spurs is not going to help people out and can make them worse, because then they have a lot of arthritis, then they have more motion, which can create more pain. Posterior impingement we see with our ballet dancers, soccer players, runners, downhill runners specifically. Overuse often can be an acute injury as well, like an ankle sprain. Lateral and oblique views are treated by injections, and sometimes we go in and remove that, most commonly by small incisions, but can be done by a scope like we saw. Okay, so do you guys want to take a little break, or do you want to do a couple more questions?
Let's keep going.
Anyone? Okay, want to do some questions? So who's next?
I can do this. So figure 1 is radiograph patient with a history of pain at the insertion of the Achilles tendon who sustained a sudden onset of severe pain when jumping off a horse. On examination, the patient has lost plantar flexion with Tom's test and pain with palpation of the distal Achilles. What's the most appropriate treatment? So it sounds like concern for insertional Achilles tendon avulsion. So we're going to be doing surgery in this case.
Right.
So the only
those do not, those don't heal with non-operative measures like our other Achilles.
Yeah. So the only surgical option is D.
Correct. Okay. And with possible FHL, exactly. Usually we do those around in people that are older than about 55. Okay, next.
All right, I'll pick Nick Vitariano. Okay. How about Aaron and Monica? Looks like they're both teaming up.
Sounds good. Figures 1 and 2 are the MR and ultrasound images of a healthy, active 64-year-old man who has anterior ankle pain, difficulty ambulating, and an abnormal gait. These symptoms developed insidiously 2 weeks ago and worsened after a recent misstep while walking. What is the best treatment option?
What do you see here?
It looks like some soft tissue structure in the anterior aspect of the ankle that looks like it's maybe retracted, potentially. So on ultrasound, for
Right. What do you think that is, maybe?
I would assume that there is some tendon that's probably ruptured.
Yeah.
In there.
I don't know what's going on with that. Yeah. What do you think that is?
So going back to the answers, you would need. I guess it would be a surgical issue. You can't orthoflex, so I would, probably primary tendon repair with possible graft.
Right, and so that's the tibia they usually classically feel. It's usually a non-traumatic injury. They often feel a big lump on the front of their ankle. Literally, they feel this big lump and swelling. And then their foot slaps on the floor, and that is a tibial rupture, and we repair that. Because you can imagine if it's insidious onset, it's wear and tear, and it just doesn't heal primarily very often. So often we augment it with graft. Okay. Okay, next.
How about Sachin?
All right, so we have a 41-year-old male, sustained a twisting injury running upstairs 4 weeks ago, was treated an ankle brace, has been bearing weight since the injury, no history of ankle problems, but he's got pain, swelling, and instability, worse with stairs and on unlevel ground. They tell us the radiographs don't show a fracture, and 3 months later, the patient has continued swelling and giving way episodes, and we have stress radiographs, and we'll just look at what ligament.
Let me get those for you. Okay. So what do you see here, Sachin?
So I'm assuming on the right side they're doing anterior drawer testing.
Correct.
On the left, looks like a sort of inversion testing.
Yeah, the Talar Tilt, right?
Yep.
So which one do you think looks abnormal?
The inversion stress test. No, but I mean both. I mean the anterior drawer. It's not like, it's not a perfect lateral.
It's not a great example, but you can blame Fogoni for that. No, just kidding. I'm just kidding. No. No, I think what they're trying to show you, again, it's not a great test. It's not a great, but there's a little bit of asymmetry here as compared to here.
Yeah.
Whereas this, this is not a great example either, but because there is a little bit of widening, but I think this is what they're going after here. So which one, basically, which one do you think that is then?
Probably their anterior talofibular.
Yeah, exactly.
Because they have anterior drawer and inversion stress test abnormalities.
Yeah, exactly. So they're just trying to get you to say that's anterior. And in obviously in a board testing question, it's going to be much more obvious than this subtle one here. So
cool.
Okay. All right. So again, focused physical therapy, proprioception. So they talk about 5 millimeters as the cutoff. So I would agree with you. That doesn't look like 5 millimeters to me either. So.
Awesome. Yeah.
Okay. Next one.
I'll call on William's iPhone.
That's me. All right. Let's see. 45-year-old active man with a mild cavus foot developed chronic peroneal tendinopathy that failed non-surgical treatment. Everyone has intraoperative photo of the peroneal tendons found in a sheath inferior to the peroneal tubercle. Appearance of the other peroneal tendon found anterior to the peroneal tubercles was normal. What is the best treatment option?
So what do you think that tendon is? We were talking about that a little bit earlier. We'll go over that in the next section, but inferior to the tubercle. Remember, we're talking about the tubercle is distal to the fibula. So which one do you think is injured?
Will, you're muted if you are talking.
Oh, really? Oh, sorry. I said brevis.
So brevis is that dorsal or plantar?
The brevis
superior,
is
inferior.
So I guess it's superior, right?
Right. So brevis attaches to where?
The base of the fifth.
Exactly. And where's the longest attach? Or where
Longest
does it go?
goes plantar, basically.
Yeah, exactly. Right. So which one do you think is inferior in the sheaths?
The plantar, one, the longest. Sorry.
Yes. Yes, exactly. So then what do you think you would do with that one?
Well, let's see.
What do you think? Oh, wait, we need to look at the photo. Sorry. Oh, sorry. What do you think that looks like?
That looks like a torn tendon.
Right. It's ruptured, right? It's completely ruptured. So knowing what you know about the anatomy, what do you think you would do with that longest?
So we're going to do an answer with the longest. You can't just debride it. You probably need to repair it. Yeah, so it's going to be repair of the peroneus longus tendon.
It is. How do you feel like how are you going to get that other tendon underneath the foot, and how important is that? So the tough part about the longus, it courses underneath, and so when that is really degenerated and ruptured, because this guy has Catus foot, then usually we try to keep the tendon, but it's really hard to repair that primarily.
Okay.
And we try to keep the tendon, so then we can transfer it. And we will talk about this again. These are questions that we will go over in a second. But we would debride it and then transfer it to the brevis. Okay. Again, we'll go over this. Okay. Next.
Oh, do I call on someone?
Yep.
Let's see. Sarah Stroud, you're the first person I see on my screen here.
Okay, let's do it. A 41-year-old man sustained a twisting injury while running upstairs 4 weeks ago. He was treated in an ankle brace and has been bearing weight since the injury occurred. He has no history of ankle problems, but now he has ankle pain, swelling, and instability. The pain is aggravated by stairs, and the instability is worse on unlevel ground. Radiographs do not show a fracture. Figures 7 and 8 are this patient's intraoperative arthroscopic images. The abnormality seen here illustrates which of the patient's clinical findings. So it looks like we're looking at.
What do you think that looks like?
That looks like an OCD to me, like an unstable OCD.
Where's it coming from, do you think?
The talar dome looks intact. It actually looks like it is potentially from the tibia.
So then what do you think?
So it's not D. We think it's tibial, not talar. I think it's probably ankle pain and swelling that he's experiencing from this.
Right. So ankle pain and swelling, exactly, because the talus, they're just trying to get you to identify that. And we can see maybe from the tibia LCD, but sometimes also just from a chipped off anterior osteophyte, we see loose bodies like that too. Okay.
And I think
all right.
Steve Garcia.
Yep, 41-year-old man sustained a twisting injury while running upstairs 4 weeks ago. Treated an ankle brace, wearing a brace since the injury. No history of ankle problems, pain, swelling, and instability now. Aggravated by stairs, instability is worse than uneven ground. It's the same vignette. Radiographs do not show fracture. What's the appropriate treatment? We begin a structured proprioceptive rehab. And brace is needed. Discontinue brace, start aggressive range of motion. Physical therapy is short. Like weight bearing cast for 4 weeks, maintain not weight bearing status on crutches for 4 weeks. So I guess this is assuming he still has ankle pain, swelling, and instability. Yeah.
What do we talk about for an ankle sprain?
I'm sorry. I was talking over here.
So what do we talk about for the ankle sprain?
Yeah, so I mean, he hasn't started any therapy yet for first line. So he needs to do that.
Right.
So I think
begin appropriate rehab.
Yeah, it should be A. Yeah.
Yep. Exactly. Yep. Okay. So just like we talked about. Okay.
First person that hasn't gone on my list is, I think, Tiffany. No, maybe Tiffany's gone. Tiffany.
I haven't gone. Yeah.
Okay.
So a 30-year-old distance runner has a 6-week history of mid-substance Achilles tendon pain and swelling. After an initial period of immobilization, a course of rehab was recommended. The most appropriate rehab regimen includes, so we have discussed this before, and it would be eccentric exercises.
Right. Again, repetition is key. You guys are seeing the same things over and over, right? So eccentric exercises is what gets these better. Okay. All right.
Let me see. I can't remember who has it on. Kaz, are you there?
I am here, yes. Okay, so 18-year-old competitive volleyball player sustains inversion injury ankle 5 weeks prior. During play, he landed on the ankle and felt a pop. He is unable to turn and was given air stirrup and crutches by his trainer. He is unable to weight bear, but continues to have pain about the lateral ankle and hind foot with any impact activities to the extent that he can no longer play. He is otherwise healthy and denies any previous difficulty or injury to the foot or ankle. Radiographs and MRI scan were ordered by his primary care physician and are shown in figures 1 through 4. Based on these findings, what is the diagnosis?
Okay.
We can take a look at the imaging.
This is a little tricky to see here.
Okay. Looks like there might be like either, I think, would that be like an os trigonum back there?
Yes, you're correct. There is an os trigonum here. It's hard. I don't know if you can really see it on this one, but do you see anything unusual on this MR cut here?
It looks like there's probably some, maybe like some bony edema there.
Yeah, exactly. Like right here, you see that? I know it's kind of hard to tell, but you're exactly right. There's bony edema here, and there's some bony edema kind of here. And do you know what that is trying to lead you to look at? But you're right, there is an os here too. I think what they're looking at here is the os looks like it's partially connected here, here.
Okay.
And so I think that this is what they're trying to lead you to.
Is that like
so? Do you think that there's a occult distal tibia fracture?
I do not think that's what it is. Ankle sprain, posterior ankle and pigeon. I think what it's getting at there is probably the coalition of the subtalar joint.
Yes, exactly. So again, our young person, right? Exactly. And you can't see it very well on this, but what they're showing you is exactly, that's why again, all these things, every piece of information they give you is a clue. And so that's why showing you this here, they're showing you something, and you don't see the os here, right? This is a coronal cut. And then you have to think, well, why are they showing you this cut here? You know what I'm saying? Like these questions are vetted and they're pretty tricky. But every sentence and every part of the question and every image they're giving you is displaying something, and that's why they're showing you this. And then if you really look here, you can see the edema too.
On the X-ray, is that like the C sign, or is that, am I thinking of a different sort of like keyword?
Yeah, no, they're talking about the C sign as well. Yes, exactly. So that's why they're kind of showing you all these things to lead you to that. And then we know that this is a young person again. Doesn't always have to be young, but the key is that they're showing you, and the coalition of the subtalar joint is often of the middle facet, and it's that most commonly seen on that cut of the MRI that you just saw, that coronal cut. Okay.
Okay.
All right. So next.
Next.
These are tough questions, guys. So you guys are doing a good job.
I think, is Sergio on here? No. What about Joey? also not here. Maybe Ryan, have you done one in a while?
I haven't. Well, I have, but I didn't want to go back. I'm happy to do this one.
Okay.
So after surgical repair of an Achilles tendon rupture, a protocol that uses early motion has been shown to decrease which postoperative complication. It's not cerebral nerve injury. I don't think it's re-rupture. So it's either loss of calf circumference or loss of ankle range of motion. I'm guessing it's loss of ankle range of motion. But
this is a tricky one too. Just
sure.
you kind of just have to know, and again, we'll kind of talk about it. But it actually is. This is why we early motion, early weight bearing. It's because we think that it actually decreases the re-rupture. Yeah, exactly. This you would think that this would be the case. This is only because we haven't gone over this yet. Yeah. So understandably, again, these are kind of tougher questions, but hopefully by the end, you guys will kind of be a little bit more familiar with these. Okay, next one here.
Right. To be fair, 50% of people also were wrong with me, so I'm okay with that. I think Fabian, have you gone yet?
All right, figures 1 and 3 are the standing and stress radiographs of a left ankle of a 48-year-old man with chronic left ankle instability who's scheduled for a lateral ligamentous repair procedure, which anatomic factor may predispose this patient to recurrent injury.
Okay, so you see here, what do you see there? So this is obvious, right? They're showing you, this is what you're going to see on a test. These kind of obvious, right? That unlike the last one that Sasha answered.
Yeah.
But yeah, so what do you see?
He has hindfoot varus, I think.
Right, exactly. You can see a tall calf pitch, right, really high.
So that would be back to the answer choices, varus hindfoot.
Right. So metatarsus primus elevatus. What do you think that would give you? That would make they're talking about your first ray is elevated up here. Yeah. That's going to flatten your foot out, right?
Okay.
And that's why that's not the answer as well. Okay. So yeah. And those are like again associated with flat or pes plana vagus.
All right.
Okay, so that is our end of our slideshow.